honor of introducing Professor Dr. Sabe, who is an Associate Professor of Medicine at Western University, London Health Science Centre. He's also the Director of the Echo Lab there, and he's also the Fellowship Director of the Echocardiography in London Health Science. So we're very honored to have him today. Personally, I know Sabe for a long number of years, and at almost the beginning of his academic career in Canada, back from Cleveland Clinic, he's been like a really strong force in education and multiple other areas, a very active member and contributor to the Canadian Society of Echo. And I often consider Sabe one of my best Echo friends, many, but he's one of the good ones because we share lots of common interests, including education, medical IT, as well as watches interests. So he's my watch buddy. That whenever we catch up with one another in any of the meetings, we'll say, like, which one do you have? So I think these are great hobbies. And I told Sabe, I actually, and many of my trainees, that I examine all my patients' watches, and that tells their personality, as well as create a great conversation. So without further ado, I'm going to pass it on to Dr. Sabe to share with us one of his actually favorite topics: mechanical circulatory support and echocardiography. So please go ahead.
No, thank you, Qiming, for the kind introduction, and thank you to you and Priya for the invitation. Like I say, I'm down the 401 in London, Ontario, but I really consider St. Mike's like an extension or a sister lab. I'm always reaching out to Dr. Chow as well as Dr. Liang Poi for how things are done there. Always, they've been great mentors and friends to me, and really helped me in my career. So I'm really, really pleased to be here and present this. Now, I'm an echocardiographer, but my clinical interest is in heart failure. So I do advanced heart failure and transplantation. I'm part of the team down there. Here are some disclosures. And the thing is, with the mechanical circulatory support, is this field is exploding, and it really doesn't matter where you work, what hospital you're at. Patients with mechanical circulatory support come to the emergency room. They are in your ICUs, they are in your CCUs as this care is becoming more specialized. And I think just having an appreciation of how you do echocardiography, even if you don't deal with a lot of LVADs, is very important. The principles are very simple and based on just basic imaging as well as Doppler concepts where possible. And I'll take you through how we go through both durable and temporary devices. So what is the role of echocardiography for mechanical circulatory support? I'll be calling it MCS for short. So first of all, it helps us guide patient selection for the proper device. Which device for which patient? It depends on patient clinical characteristics, how sick they are, the state of their LV, their RV. We'll talk a little bit about what we look at before we select a device, or if we think they're good for a durable LVAD. It allows us visualization of when possible, of device components. In truth, we don't always see cannulas very well on echocardiography, but if we know to look for it, we can often get it through focused views. We can see the response to therapy. So if we put in, a device as a heart failure therapy, some of these patients may recover their LV function, some may not. But while it's in there, you're going to be putting in for different reasons. So you may be putting in an ECMO circuit, and you may be looking for signs of myocardial recovery that may help you with weaning a device to explant. Oftentimes our devices for durable devices, and durable are the ones that people are walking around with, the most common one being a HeartMate 3. They have complications, they have device alarms. Patients come to the emerge when they get alarms. They call the VAD coordinator. And just having a basic idea of what these alarms are and how we deal with them is very important. And all of these devices have different pump speeds, and having some idea of optimizing these pump speeds and when to wean, as I said, is very important, and echocardiography does play a role in all of these facets. So for a long time, this was the seminal paper in 2015 by Ray Steinbach, and it was due for a revisitation for many years. And lo and behold, Ask and You Will Receive, almost 9 years later, this newer guideline came out, and it's a long guideline. It's I think above 60 pages. I would definitely encourage you guys, especially the trainees, to give this a read. It's very comprehensive. And it marries both clinical and echocardiographic aspects very nicely. Just in short, the differences between this and the earlier guideline is a little more of a focus on the temporary devices, things like Impella, ECMO. I'll explain what those are if you're not familiar with them, but it's definitely, this is the paper that I'll be, when I used to do this talk before, the previous paper I'd be referring to now, I try to make it as contemporary as possible. So you can see here that when we look at a patient who has a left ventricular assist device, unfortunately, the price of supporting our patients mechanically and hemodynamically is at the expense of potential complications. And you can see here that in a lot of these complications, aortic insufficiency, right-sided heart failure, pump thrombosis, echocardiography is often the first line of taking a look. Now, let's talk a little bit about the devices, just give you a lay of the land. So we can support the left ventricle or the right ventricle through various different circuits. We have the centrifugal devices as well as axial flow devices. I'll explain the difference in a second. It basically comes down to how the blood is aligning with the pump as it enters the ventricle. In terms of pulsatile devices, the intra-aortic balloon pump is an old workhorse, not a great perfusion device, providing about 1 liter per minute, whereas these other devices are providing, up to 6 liters per minute and restoring cardiac flow and output. The right ventricle can be supported with an Impella on the right side via ECMO as well, and a tandem heart, but we'll talk a little bit about this later on. So we have two different categories: durable MCS, which is where HeartMate 2 and HeartMate 3, this is an older slide, as well as short-term MCS, where ECMO has really seen a revitalization in the last few years. Centromag is a very popular surgical device that can last a patient up to a month. So if you're looking at patients that may be waiting a long time for a transplanted heart to come, this may be a device of choice because you've got about 30 days on it. The devices vary in terms of their ability to support the RV, and the one thing that you must note is all of these devices can have thrombus associated with them, and so anticoagulation is very important. If the patient has a contraindication to anticoagulation, these devices are simply just not gonna fly, and we're going to be looking at problems. So let's start with the durable VADs. We'll talk about the best known device to date, considered the best device on the market right now, which is the HeartMate 3 that's been on the market for a few years. And I want to just break this down into several, three key components. So basically, there's going to be an inflow graft that goes at the LV apex. The inflow graft on the outside has the Impella, or the pump is actually housed there. And from there, blood is brought in, taken through the pump, and then redelivered via the ascending aorta. And there's an anastomosis with this outflow graft or cannula and the ascending aorta. Now from there, there's a drive line that comes down and it goes through the skin. And then this communicates with the patient's controller and provides the patient with information regarding alarms, pump speed settings, etc. So most patients are very good, and there are 2 battery packs as well. A patient always has a backup battery, and they're usually very well versed in how to use these devices. It does require some level of competencies, which factors into the patient selection in terms of using these things. The other thing is too, you have to also be, for some of the fellows and stuff watching, you have to be a little bit used to how the X-ray appearance of this HeartMate 3 appears. It kind of comes at an oblique angle with the apex here. You can see the inflow cannula highlighted by the arrow here, and the star, once again, is showing you the Impella or the pump in this patient. Now, across the 3 devices, so the HeartMate 3 is a centrifugal device, and what a centrifugal device means is that the blood is basically entering from the rotor or the pump into the LV at a 90-degree angle, where the HeartMate 2 and HVADs are axial devices that enter in parallel. The HeartMate 3 is typically housed in the peritoneal sac, where the HeartMate 2 and HVAD are often extra peritoneal. And the only thing that we can actually change in an LVAD, so you know, is a pump speed. Everything else is a derived parameter. So there's different algorithms, which I won't go through. I'm going to focus on the echo side of things, but the HeartMate 3 out of the box usually spins at about 5,000 to 5,200 RPM, and we can adjust this in increments of about 100 RPM going up or down. We'll talk a little bit about what goes into that. And it restores a flow that is near normal, a flow of about 4 to 6 liters per minute. And there are different parameters, including power, pulsatility index, which often is like the JVP of the heart, will mirror volume status. But these are all derived, and flow is often what the number reflects what the ventricle is seeing. So if you have a low flow situation, often it's the most common cause of that would be high afterload or high mean arterial pressure. But these are more slicker algorithms that with a lot more nuance that I will spare, but we'll just focus on the imaging here. But just so you know, these speeds vary across these devices, but this is the only parameter that we can actually change on an LVAD. So once again, TTE, or transthoracic echocardiography, is the first line look at these patients. As part of routine surveillance, we're going to be looking at LV and RV size and function, get some hemodynamic assessment. Where possible, we're going to be interrogating the inflow and the outflow cannula. Just having a good visual assessment of things like septal position, degree of regurgitation across your aortic, your mitral, your tricuspid valve are very important. If you can look at the outflow cannula, great. Often it's very difficult to image. And sometimes we have to use multimodality imaging. Patients get driveline infections. They have fevers. We use FDG PET. Complications, early after the LVAD is put in, there may be cardiac tamponade, which is rare, but more commonly we may see some RV dysfunction. Once we unload the ventricle to such a degree, the RV sometimes takes over, or can be related to the volume of fluid that is given immediately in the peri-op to post-op setting. And you can have, especially if the patient had pre-existing RV dysfunction or pulmonary hypertension. Low flow alarms have an entire algorithm to themselves, which echo can help with. Infection as well. And there are second line things that we can do. So for pump thrombosis, oftentimes a CT can be a lot more helpful. You can see cannula if there's something going on with the cannula, if it's kinking or twisting, or you can get a little bit of idea if there might be a pocket of infection elsewhere within the circuit, outside of the heart and the actual chambers that we only see on echocardiography. So once again, echocardiography plays a very important role pre-implantation, intraprocedurally. We really rely on our good cardiac anesthesiologists who are very skilled at imaging these devices, looking very carefully at the inflow, the outflow cannula. The degree of regurgitation should go down, especially mitral regurgitation. And post-implant, we're going to look at these other things as well, which I want to show you in a little more detail. So the newer guidelines, if you look at it, there's often some red flags, that, if you will, in terms of what are things that we look at that may portend a poor prognosis when we're looking to implant a left ventricular assist device in a patient. And small heart size is one of them. So the LVAD of less than 5.5 centimeters. Volumetric assessment for patients who get an LVAD is often very difficult. With contrast, it can be done, but the LVAD is considered a little bit of a more reproducible marker, if you will, of ventricular distension in these patients. And if you've got a very small LV cavity, recall you're going to have an inflow cannula that sits at the LV apex, and that cannula is quite large. So small ventricles, typically you need the bigger the ventricle, paradoxically, the better the patient does with an LVAD, because that inflow cannula is nicely spaced from the septum. And I'll show you what happens in small LV cavities. You can have something called suction, where the inflow cannula rides up against the ventricular septum. LV trabeculation, LV thrombus, oftentimes you may need to have your thrombus removed either through aggressive anticoagulation or thrombectomy at the time of the apical inflow graft implantation. Aneurysms as well can be an issue. We had a case here a few months ago where there was a large pseudoaneurysm, which had some clot that probably wasn't appreciated at the time that the LVAD was put in, and the patient had a stroke, unfortunately. The RV, in terms of assessing the RV in patients in general, is very difficult because of the ellipsoid nature of this chamber. We call it the forgotten chamber. But the newer guideline does talk about looking at this RV to LV ratio, particularly in the apical 4 chamber. And if this is above 3/4, it portends a poor prognosis. If these diameters are above 0.75. PFOs, ASDs, intraatrial shunts, these typically need to be addressed at the time of LVAD implantation. You're going to have a significant unloading of your left-sided pressures, which can just worsen right-to-left shunting in these patients. And then valvular abnormalities typically need to be addressed at the time of the LVAD implantation. So any aortic insufficiency, more than mild, sometimes it can get away with a Park stitch to get rid of it. Aortic stenosis can be addressed. MR oftentimes, an annuloplasty ring may be placed, and the MR should come down. Functional MR should improve with LVADs, pulmonary stenosis, or greater than moderate PR. So, I'm sure many of you know, one of the key issues. Okay, good. Just 1 second here. Is the large RV or RV dysfunction post LVAD implantation, and who gets this is not entirely clear in terms of prediction. Oftentimes, hemodynamic parameters such as PAPI, which is a formula that uses the RV systolic and diastolic, as well as the wedge pressure in there, that can help you predict to some extent, but this is often very difficult to tell. But it's very difficult to manage as well when a patient has an LVAD in and you've basically supported the LV, but now you've got RV dysfunction that can be transient, or it can get better with time. So very careful patient selection prior to putting it in is important. Now, once again, you can see this is a patient where there's you can see that these are a couple different views where we're looking at the RV and the LV ratio, and I believe these are pre and post implantation, and greater than 0.75 has a very bad prognosis. So it's a good segue, at the time that we get in your guidelines, sometimes they kind of cluster, and this right heart guideline done by Dr. Rudsky, who has been a champion for this, as the chief, the main author on the initial guideline, I believe back in 2010, and the new iteration of this has brought into not to go tangential, but certainly it brings into play the RV focused view as well as the right atrial focused apical four-chamber view. These are the right atrial focused view is a newer concept in the literature. The thing I like about this guideline as well, and I remember many years ago emailing Dr. Rudsky what his criteria are for mild, moderate, and severe RV dilatation, and he said you can use any number you want. It really wasn't given anywhere, so it wasn't just me, but now lo and behold, asking will receive, and you can see that RV size is now quantified into mild, moderate, and severe. They actually come into cutoffs with the RVSP. This is many of you, if you're a little bit older in age, know that this has been a moving target between 70 and 80 for severe pulmonary hypertension. They're calling it at 70, but you can quantify now mild, moderate, severe based on TAPSE, RVS wave, volume. So especially for some of the trainees, if you haven't looked at this document, please look through it. But I really do like this particular table, and I printed it out for our lab, just so it's there as a reference. Now, so let's take a look at some of the imaging of the LVAD. So this is a HeartMate 3, and you can see here in the parasternal long axis, we see this apical cannula here. And this is an old Heartware or HVAD device that has since been recalled, and there's nothing wrong with this device. This is just a blooming artifact. Different devices have slightly different color velocity profiles that you need to be a little bit familiar with if you're looking at these on a regular basis, and this is just a normal appearance with this blooming artifact. Now let's start with the ingredients. So I said the first bit is the inflow cannula, which is basically at the LV apex, and this is best assessed in the apical 4 chamber, the apical 2 chamber. You want to get some idea of the alignment of that cannula. If you think, I'll show you what a normal angle should be and how it should be vis-a-vis the septum. You want to look for significant mitral regurgitation, laminar flow on colored Doppler, and you want to evaluate the flow characteristics. So normal inflow velocity can be up to 2 meters per second or 200 centimeters per second. Sometimes you get acoustic shadowing. We don't typically do a lot of TEE at our center on LVADs, And you should do peak and continuous wave Doppler of both systolic and diastolic velocities, and typically less than 1.5 meters per second as considered normal. So you can see this is an image that I borrowed from the earlier guideline. And you can see that at the time of implantation, this if we draw a line up or perpendicular from the apex from the cannula, it sits flush and perpendicular with the tips of the mitral leaflets and the mitral annulus, and this is considered an ideal or optimal position. It should bisect the mitral valve leaflets here as you draw the line upwards. So I just, I actually remember using this guideline to work through a case. This was a case from last year, and this was a 52-year-old male with an ischemic cardiomyopathy post LVAD implantation. And the surgeon called me and said, I just don't know what's going on here because the X-ray looks really, really funny. So like I said, this is a normal appearance of a HeartMate 3 chest X-ray where it's kind of oblique, if you will, and coming in with the apex, whereas this one seems to be, it seems to be just on fast with the LV in this chest X-ray. So it's a very abnormal looking chest X-ray. And I looked, so I just remember the principles from the guideline paper, and I looked in the intra-op TE, and this is what it looks like. And you can actually see that it does actually fit the criteria of being fairly flush and bisecting those mitral valve leaflets if I were to draw the line up from there, and which I do here. So the cannula position or angle is reasonable. It doesn't seem to be angling towards the septum. But the issue is that the pre-implant transthoracic echocardiogram, this EF was 35 to 40%. It wasn't the sickest, if you will, ventricle. And the end diastolic volume of 150 cc's is very mildly dilated for advanced heart failure. Typically, we're putting these devices in patients who have ventricular cavity and diastolic volumes of 400 cc's or higher. So this is very small LV cavity, kind of like I was suggesting earlier, and that's probably why that inflow cannula is just has a funny appearance on the chest X-ray. The outflow cannula is best visualized in the high-long axis of the ascending aorta. Think about trying to get a good shot of your ascending aorta, getting those high measurements, and getting that high-long axis. It's localized at the right anterolateral aspect with end-to-side anastomosis. There's outflow velocity of 1 to 2 meters per second with unit directional, slightly pulsatile flow. And there's acoustic shadowing artifact that, once again, may require evaluation. And if you're worried about the cannula itself, kinking or of the outflow cannula, then a CT thorax may be helpful. So here we see that high parasternal view, the ascending aorta here, and an outflow cannula. And here it's in the normal position, and the color flow velocity profile is actually normal. It's actually less than 1 meter per second in velocity. AI in the LVAD patient is a subtle but very ominous finding. And here you can see AI is continuous in nature, much in keeping with the cover of JACE when they published this guideline in 2015. As you can see, basically there's aortic insufficiency occurring while the mitral valve is closed. So it's occurring both in systole and diastole. So things like our standard formulas like regurgitant fraction, do not apply to an entity that's occurring both in systole and diastole. And this is continuous aortic insufficiency. Now, the problem with aortic insufficiency is normally the aortic valve is closed or open very intermittently to clear the LV. And you can get, here, 1 being the aorta, here's the aortic valve, 2 is the LV, 3 is the inflow cannula, then coming up through the Impella number 4 to 5, the outflow cannula, and then returning back to the aorta, through the aorta to the rest of the body. You can see that if you have aortic insufficiency here, you're going to have a futile cycle where blood, instead of going forward to the rest of the body, just keeps getting hung up in the circuit. And, there can be a snowball effect where more and more AI begets more and more AI. So the assessment of aortic regurgitation in LVADs, it is somewhat difficult to quantify. They have proposed in the newer guidelines looking at the outflow cannula and the S to D ratio that is inversely proportional to aortic regurgitation severity. Or you can look at the diastolic acceleration of the outflow cannula flow, a metric that is directly proportional to the aortic regurgitation severity. So you've got at least moderate or higher if the diastolic acceleration is greater than 0.49 and the S/D ratio is less than 5. So here we can see an S/D ratio of less than 5. This is less than 49, that diastolic flow. This isn't a parameter I honestly look at that often, but this is suggestive of significant aortic regurgitation. The aortic valve and its opening is very important. Typically, back in the day when I trained in Cleveland many years ago in 2008, there was a philosophy at that time that your pump speed should be such that your aortic valve is open with every beat. Now, we've come to know that feeling is detrimental, and it should be closed most of the time and open somewhat intermittently. You need to set a pump speed to balance LV unloading and AV function. There's persistent closure that can be associated with degeneration and thrombus. And once again, AI, and what happens over time is you can get a commercial fusion that occurs at your aortic valve. You can get AI that occurs, and the closed valve is exposed to systolic rather than diastolic pressures. So with a ramp study, this is where we're adjusting the pump speed to a speed that we think is optimal. There's several kind of big picture or gross items that we take a look at on echocardiography. So the thing with the LVAD is that what happens is it causes a significant unloading of the left ventricle. But this is going to result in an interplay between your LV and your RV dictated by what the septum does. So at higher pump speeds, generally speaking, we get much more unloading of the LV. The LV cavity size shrinks. The septum then may veer leftwards and the patient may get more RV dysfunction at that time. So if you're adjusting a pump speed and you see an extreme leftward shift in your septum in a patient with an LVAD, or I should say, if you see this extreme leftward shift, the first thing to question is there a high pump speed? Could there be severe TR? Could there be significant RV dysfunction? So ideally, we want a septal position that is as midline as possible. This is a beautiful paper that was done in 2018 by Karima Adisha, who trained under the late, great Roberto Lang. She's Canadian, very well known in the 3D world. And she worked with Roberto Lang, who passed away this past week, so condolences to him. But you can see here that in this nice paper, she shows that generally speaking, at the higher pump speeds across different devices, the LV volume goes down and the RV volume tends to go up. And this is just a ramp study that I had done in my first month as a staff. I'm just going to play these individually. And this is the old HVAD device. This is my first month working in London, doing some ramp study, just getting down to business. And it's hard to tell, but at the higher pump speeds, you may appreciate we're going higher as we go from here to here to here. There's a little more septal shift leftwards. It's very subtle, but potentially there. Pump thrombosis, these machines, they have a rotor. There's a lot of hardware in there. And just like any prosthetic device, it has a potential to be not only infected, but also have a thrombus associated with it. And pump thrombosis, for whatever unclear reason, kind of peaked around 2012. This is data across 3 different institutions that was presented by Randy Starling, from Cleveland Clinic, somebody that I got to train with many moons ago. And this is kind of what pump thrombosis looks like on the rotor itself. So sometimes you don't actually see it on the echocardiogram. It's housed within the rotor. Pump thrombosis has its own algorithmic approach to it. It might be in a device alarm where the patient's power is increasing. We typically, in our standard blood work for an LVAD, look at the LDH, which, as many of you know, is a marker of hemolysis. This may go up. The patient may have markers of hemolysis or new heart failure symptoms. And then what you do if the patient has pump thrombosis is another very nuanced discussion that ranges from thrombolytics to just increasing the anticoagulation, adding different agents as well, bivalrudin, things like that. But I won't get into that. But pump thrombosis is something we need to be aware of. Now, the issue with pump thrombosis in a VAD, it's not like an LV thrombus or something like that. It would be nice if you could just see it all the time at the LV apex, but it doesn't always sit there. That thrombus can be anywhere within the circuit, so you have to marry your clinical clues along with your echocardiographic clues, and sometimes employ additional imaging like a CAT scan or a PET scan. So the thrombosis itself can be pre-pump, it can be intra-pump, or it can be post-pump. And This is a paper done many moons ago showing that if you actually look at your inflow cannula, the diastolic component of flow is more the contribution of the LVAD itself. And this contribution becomes diminished when you have pump thrombosis, such that your S to D ratio increases and your diastolic volumes, your diastolic velocities are coming down. And this is true in this case of this patient with pump thrombosis, both in the inflow cannula and the outflow cannula, as you can see in the diagram here. So I was looking for a couple cool cases just because I know that you guys really are. I love all the imagery that is in your presentations that I've watched on the YouTube channel. Not all of them, but some of them. And sometimes what's rare you don't see every single day. So I do like I do like to read the open access journal Case by Vince Sorrell, who's a friend of mine, and I would encourage you. It's a great place to look and submit cases as well, put on by the ASC, and you can find almost an interesting case on anything that you're looking for. That's very contemporary with a nice brief write-up. So definitely a little plug for that journal. But this is a case that I did find for this presentation. This is, just to show, so it's a 71-year-old male who had a HeartMate 3 with a recent, not so obviously at a different institution, but they had a recent outflow, aortic outflow thrombus around the aortic sinus on CT. They were placed on warfarin. They weren't particularly ill because of this. And around the time of their HeartMate 3 implantation, they had a mitral annuloplasty repair. And you can see, so the patient was discharged, being anticoagulated. And in the case report, they described the patient having a subtherapeutic INR for a period of time, and then coming in with cardiogenic shock, high LFTs, high lactate. And you can see on the TTE that the left, you can see the small thrombus on the TEE here in the long axis view, and on 3D you can see that the left coronary cusp and the non-coronary cusp are both fairly immobile because of this small thrombus that is there. And the patient had significant aortic insufficiency. And in fact, it's not only severe aortic regurgitation, they also had significant mitral and tricuspid regurgitation. And interestingly enough, their LVAD inflow and outflow velocities were less than 2 meters per second. This was a thrombus that was just sitting within the aortic sinuses. And the patient ended up undergoing aortic root thrombectomy, closure of the aortic valve, tricuspid valve repair, and an LVAD outflow graft revision. So the real teaching point, I think, from this is AI, you don't typically see this much, but AI in an LVAD patient, this is about an extreme as it gets, but AI does typically portend a poor prognosis. Getting back to smaller LVs, just looking at complications of this, this is a patient who has a inflow cannula very close to the septum, and oftentimes the patients themselves don't complain of anything but they're actually in ventricular tachycardia because this is a suction event where the apical cannula is running up against the septum, but they are protected from the VT hemodynamically because they have support on their LV. The long-term sequelae of VT storm in these patients can be RV dysfunction. Will eventually catch up with them, but you have to do an ECG as soon as they come in or put them on a monitor to ensure that there is no VT, but this person had VT on telemetry. This is a great image given to me by one of my cardiac anesthesia colleagues that immediately after they put the LVAD in, there was this complete suck down. So this is where the LV should be, but you can see it's just squished down and it's just riding up against the septum, the apical cannula, and it's actually pulling in the contents of the left atrium within the LV. Let's shift gears, talk a little bit to some of the temporary devices. Shock teams become part of our newer landscape in cardiology and critical care. These newer devices, which device is a much bigger discussion. But I will tell you briefly, there's a tandem heart, there's an Impella circuit, which can be a 2.5, a 3.5 in RP, or a 5.5, each one denoting the amount of flow that they can give. Some of them do require a surgical cut down, like the Impella 5. And they do have the potential to support the RV as well, but you need a double circuit for them. Some of the Impella, the 2.5s, the CP that's put in the cath lab, these are more post-MI or somebody has high-risk anatomy like left main. It'll give you a support for a few days, but if you're looking at somebody for the longer haul, like a month or so, you probably need a more robust device like a surgically implanted Impella or a central mag. And these are typically fairly large sheaths that are involved. You can make the circuit any which way that you want. So if you're supporting the left ventricle, the inflow cannula is in the RA, the outflow cannula is in the aorta. If you're supporting the RV, the right ventricle, then typically your inflow cannula is in the RA and the outflow cannula is in the PA. So here, one of my colleagues, Dr. Michael Chu, is a very skilled cardiac surgeon, does a lot of corrective mitral valve, minimally invasive repair. Michael's good at just a lot of things, Ross procedures. He's also very renowned for, as well as aortic pathologies. And you can see here, this is a patient, for his patients who have pulmonary hypertension and are undergoing corrective mitral valve surgery. If it's severe pulmonary hypertension, he often will put in a prophylactic CentroMag device on the right side. And this is just to give you some idea how this looks. This is a little video that was made. You get the cannula exit site. Then you see that the pump or the Impella is coming up next. This is a CentroMag pump. And then from there, you can see our cannulas here. So we have an inflow cannula in the right atrium, an outflow cannula in the PA, and the patient mobilizes with the RVAD in place, and they actually do fairly well. And oftentimes their pulmonary hypertension, it just bridges them through that period where they're high risk with their severe pulmonary hypertension. But the offending factor for the group 2 pulmonary hypertension, the mitral valve disease, has been surgically corrected. And oftentimes his pulmonary pressures will, in his small series that we did, shows that it actually stays normalized over time. The cath lab has become a really newer place for MCS, and I know in your institution where you guys are such leaders in percutaneous devices, these are part of the landscape out there for sure. There's the old workhorse, the intra-aortic balloon pump, the tandem heart, there's peripheral VA ECMO, as well as Impella devices. And Impella devices, as I said, the CP, the 2.5, these are percutaneous devices that can be put in the cath lab, whereas a 5.0 or higher often requires a more surgical approach through an axillary vein. So you can see the different configurations here where we want to see exactly a good position for our Impella, both at the inlet, which houses the, I'll show you the ingredients in just a second, but we basically are, I'll just back up to this, don't want to gloss over this too quickly, but there's going to be an inlet that, and this is kind of like the equivalent of the inflow cannula, and then we really need to image where that is so that it's not going to snare or entrap our mitral valve leaflet, and it's angulated in the appropriate manner. So this is what it may look like. Retrograde and Impella goes in, and then it gets deployed. The percutaneous ones we do not have a lot of access to here at LHSC because of a cost factor. And in the CCU, the knowledge of Impella troubleshooting and imaging needs to be known, at least at a basic level. And in the parasternal long axis, we're going to look to see where it is, in the parasternal long axis view, and it should be housed a few centimeters within the aortic valve, and over time, about 3.5 centimeters to be precise within the LV cavity from the aortic valve. And you're going to look at the LV and RV function. The patient's going to be systemically anticoagulated, and there's a P level or flow level that gradually gets weaned as time goes on. The ideal Impella emplacement, the device is stable and directed at the LV apex. The inlet zone is free floating, so it's away from the mitral subvalvular apparatus. There's a cannula bend at the aortic annulus, and the distance from the aortic annulus to the middle inlet point is approximately 5 centimeters for 5.5 and 3.5. 3.5 for the Impella CP and the 2.5. The outlet should be unobstructed and positioned within the ascending aorta, well above the aortic valve. So all of these criteria are in the newer MCS guideline from the American Society of Echocardiography. So here we see an Impella inlet cannula kind of coming very close to the anterior leaflet of the mitral valve. It starts snaring it, and the patient has significant mitral regurgitation. This is a situation that we want to avoid, and this is why looking at those angles and the deployment is very important. We'll shift gears, talk a little bit about ECMO here. So VA ECMO is used for cardiogenic shock, VBs typically for respiratory. There's a drainage cannula in the mid-right atrium, typically away from the intra-atrial septum tricuspid valve, and a return cannula in the iliac artery or the abdominal aorta. So you can do fem-fem, using, this can be done at the bedside. It's part of ECLS teams where there's you can see that there's a drainage cannula in the vein as well as a return cannula, here around the iliac. And then the blood is typically taken through a pump and an oxygenator and returned back oxygenated via the return cannula. And this is typically for cardiogenic shock. VV ECMO is usually there's a drainage cannula in the IVC, a return cannula in the mid to right atrium. So we saw an explosion of these devices during the pandemic for significant, for COVID infections, with both VV and VA ECMO being part of it. Now, Echo for ECMO. It's good for troubleshooting. These circuits are big sheets. They need to be anticoagulated. They can be thrombus anywhere within the circuit. There can be tamponade malposition as well. And these circuits can lead to ventricular distension and pulmonary congestion. They can increase oftentimes the aortic afterload can worsen with these, and we can see LV distension. And sometimes the LV needs to be further decompressed with a vent, such as an Impella device plus ECMO is called ECPella. We can look at the aortic valve opening as well. So we need to get some idea whether there's distension from high afterload. And this is something that oftentimes the management of care of is done, often driven by the CSICU teams and the intensivists. And so you can see here that these devices can lead to a lot of clots within the circuit here. As you can see, this is a patient with ECMO. I've seen these clots almost anywhere. I've seen them in the IVC looking like a thrombus in transit, but you can see them almost anywhere. Once again, just a cool case that I found in the journal itself that actually highlights a lot of these principles here. This is a 67-year-old male post-inferior STEMI that was in cardiogenic shock with a papillary muscle rupture. As you can see here, the posterior head of that papillary muscle just nicely, bopping around here on this biplane view, as well as a severe mitral regurgitation that goes along with that. And then you can so what had happened in this patient was they'd put in a VA ECMO circuit. However, they did notice that there was worsening LV ventricular distension and reduced aortic ejection. So the patient actually developed a significant aortic thrombus here, and the degree of mitral regurgitation did not go down. The patient was more aggressively anticoagulated, and an Impella device was put in to further offload to provide further venting and address the increased afterload that occurred once the ECMO circuit was put in. And you can actually see that in this case report, very interestingly, with a little time and an Impella in the appropriate place and some unloading, the aortic thrombus is gone, and the degree of mitral regurgitation has come down. Contrast helps. This is actually a nice case series that was done by some friends and colleagues, Noel Fine in Calgary and Sharon Mulvey, who formerly from Mayo, now in Dalhousie, known to everybody. And you can see that for all MCS durable LVADs and ECMO circuits, it is pretty safe. The only thing is we did have a case here where administration of the contrast, you have to kind of silence the alarms because it can shut down the circuit. It acutely shut down the circuit. So typically perfusion needs to be nearby, as it will view it as bubbles within the circuit, and it didn't provide any output. So you have to just make sure perfusion's around when they do it. We had this case that occurred in the last year, but generally they are felt to be safe both in LVAD and any form of MCS. And in this case series, they actually did show that contrast will show you a small thrombus in about 20% of patients. ECMO and weaning. So oftentimes the ECMO, people get transplanted off of ECMO, or it can be a bridge to recovery, buy you a little bit of time, so to speak. And you can look at the hemodynamic data when the patient will be on inotropes that can often confound it. But you want to see the aortic VTI is considered a healthy stroke volume. And once EF starts to come up and the VTI or stroke volume comes up, then potentially you may be able to wean your ECMO. So oftentimes for difficult cases, if they need a little bit of help, you might do a ramp study. Our ICU staff here are Some of them are quite good with TE-based ECMO weaning, but sometimes there's a lot going on. So I do get involved in some of these patients from time to time. So that pretty much wraps up my talk. Echo is a very important modality, both in patient device selection, implantation, and monitoring. Optimization and weaning can be done under echo guidance, and it's always a team approach. A combination of clinical and echo-derived parameters is best for optimizing patient care. So thank you very much again for having me. It's been a pleasure to speak to you guys virtually, and I'll just adjourn if there are any questions. So thank you again for having me.
So thank you, Sabe, as always, a great speaker and very thorough on a very difficult topic. And whenever I see these pictures, I feel I've landed on Mars with unknown landscape, and with different, like, it's without a proper map, it's really hard to figure out what connects to what, and what are some of the complications. So again, I've seen these pictures. Some of them during Echo Jeopardy, it really threw me off because it's completely different. So thank you. So maybe I'll start with the first question.
Oh, sure.
Who actually does these image, like in your institution? Is that cardiologist, anesthesiologist, or CICU anesthesiologist, or critical care staff? Who actually does them?
No, great question. So, a lot of the care of the MCS or LVAD patient has kind of become turfed or territorialized. So if it's but I think it's good to have good relations with each other and help each other when you can. So a lot of the periprocedural imaging is done by very good cardiac anesthesia. So oftentimes when there's a problem immediately post, I'll start by looking there, see what it looked like there, read the report, even ask them, how did things look? What was the aortic, what did the MR come down? Once they're in a CSICU, it really depends on who's on. Some people will ask a little more for our help on the cardiology side. Now you've got a cardiac intensivist. We are a very big POCUS institution, and you have different trainees, different staff with different competencies, different comfort level with these devices. A lot of the things that I've outlined, you can actually look at with POCUS. If you put a probe on, big picture, I look, where's the septum, what's the degree of AI, I can see all those things in outpatient LVADs. In the CSICU, it depends. Sometimes they'll employ, usually the advanced heart failure service is involved. We're a three-man team right now. We're actually a two-man team for a period of time. So oftentimes, if I'm involved, I'll take a look. My colleagues ask me. A lot of the standard transthoracic echocardiograms are done, through our cardiology-based lab. But it depends. Sometimes we're seeing more POCUS that's done. You don't really know what, the patient's had an LVAD in. It's a real-world issue. They just haven't had a standard of care, sorry to use this term, proper transthoracic, for the first week. A lot of these things, Qiming, as with prosthetic valves, LVADs, you really need that post-index TTE to serve as your baseline for where the septum was, how the heart responded to the initial out-of-box setting on that LVAD, and then go from there. So, so it can be anyone. I will say for ECMO circuits, the reason that I had to sort of look on case journal is we don't image a lot of these by TE. A lot of that stuff is done at our institution by the intensivist and their teams. There's a POCUS fellow. There's a lot of people that are taking a look, but I think that sometimes there's too many cooks, and sometimes people looking at things with different lenses can be an additive benefit for the patient. So yeah, it can be. So that's the answer for that. Oh, what is this? Is POCUS recorded? There is a program, I'm sure you guys know, QPath. The images don't stay up all the time, and it's even a typical report is not always put up there. So if you go on QPath, you can sometimes look at them. I often do make a lot of POCUS jokes at our institution. They'll want to show me QPath images, and I'll just joke with the trainee, sorry, I just ate my lunch. I'm not really interested in taking a look. But no, most of them are, they're on there, but they kind of go and come down. I don't really have a good idea of that setting, if it's cloud-based or what, but they're not indexed like they are in Accelera or a standard ecosystem. And that is, I think if the question is alluding to something that's you don't really know what somebody saw, you weren't there, which is why I do like some routine monitoring.
Yep. Thank you. So how confident are they? I guess that's the follow-up question.
How confident? How confident am I? I mean, I think I'm
Oh, it
pretty
says
confident. What's that?
in the chat is how confident are, and then it stops. But I guess it's asking about how confident are you with the recording. I think you answered that already. Basically, you
Yeah,
really need to be able to see that, right?
you know what I'll say that just to be fair, like, I have a colleague who's cardiology trained, does ICU, not level 3 echo, but very good with TE. And I mean, his images are quite good. He'll take a look, showed me the images and stuff. I have no, if somebody's taking images, I'm always happy to look, I mean, it's still imaging. It's, it doesn't, you get some idea what the are. And also for MCS, it's big picture things. What's the septal position like? What's the RV like? Is there any AI? If the patient had MR before they went in, that should come down. If there's still persistent MR, that's bad. Is there a tamponade? It's like with POCUS, I tell anyone, you should be asking if you're a non-expert, you should be using it for those binary yes, no decisions, big picture type of questions. Is the RV normal, abnormal, and so if there's images, I'll take a look, but it's when they're not always there. I don't want to turn it into that kind of a conversation, but it is what it is, and I think that the nice thing is I got a lot of friends that are big into POCUS, but they know when to ask for a bit of help, and I think that you just have to, it is what it is. I like POCUS. I carry a V-scan. It's now 10 years old. It's in my bag every day. I'm, I like to spend my money on watches, not a new POCUS every year. So, until that thing kicks out, it's going to still stay with me. And I like the old V-scan longer. And I look at all of our devices with. I've got the V-scan. It's the first thing I look at it with, because it gives me some idea what's going on. Yeah.
Great. So any other questions from the audience? Comments?
I think we have one here. Sabe, oh, sorry.
Hi, Sabe. Quick question. I find the RV pretty challenging, even in the best of times here. In your position, seeing sort of the RV evaluation with Echo, and then pretty soon after, or simultaneously seeing hemodynamics of the RV. How well are we able to sort of, assess RV function, or how well does that correlate to the hemodynamics in real time, especially with some of these devices?
Yeah.
I'm curious to know in your experience, is it something like, we have a guess with Echo, and then if the hemodynamics say one thing or another, we tend to lean on the hemodynamics, or
Yeah.
or vice versa? Where do you see if there are
No,
discrepancies, where do you see them?
no, no, that's a fantastic question. And, I personally don't do right heart caths. I mean, I'm on the transplant and VAD side, I'm more of a non-invasive side. My colleagues do biopsy, and one of my colleagues, Ryan Davey, he's really, really talented with right-sided hemodynamics. He's an interest in pulmonary hypertension, and we work very closely together. We're good friends, we're partners. And, oftentimes I think both help. I mean, when we decide if somebody needs a transplant, if the RV looks bad grossly on echocardiography, that can sometimes be enough for a deal breaker, but sometimes it's nuanced. And just as you said, it's hard to see. So, it's just like you can have an LV function, an EF that looks 40%, but the cardiac index can be under 2. Same thing, you can have an RV that looks mildly down, but the PAPI is, the PAPI is less than 2 or very low. The RV stroke volume index is, in the boot. So I think you need both, especially when the patient has pulmonary hypertension. That interplay between the pulmonary hypertension and the RV can be very difficult. So I think you need to take. I don't think any modality is the end all or be all. I think they're both very summative. If they're both good, it's easy, but you have to really pay attention to both. I mean, the right heart cath we do a lot of here in London, and I think it's a very, very helpful test. Echo, we are limited, just as you said. Once these devices go in, imaging the RV or even the LV can be very, very difficult. You're not always getting all the windows. The patient's immediately post-sternotomy. You've got a horrible apical window. That's where the cannula sits. Doing all these modified views, you really don't have a good sense of what RV is doing. And so our VAD patients too. We used to do a lot of these under echo. Now we do a lot more of these hemodynamically for ramps and stuff, and sometimes we would do both. So it really depends on I think your availability for good hemodynamics, which I'm sure is the case, at your institution, but I think it takes different eyeballs, to look at it. Nice thing is with a patient, my colleague Dr. Davey he thinks very hemodynamically. I think very structurally. I like, I'm always paying attention to the TR, all that kind of stuff. But I think generally speaking, it's like anything in echo when we're trying to correlate it. On the extremes, there's correlation. It's in that mid-moderate zone that there's a bit more nuance and discrepancy.
Great. So
Thanks so much.
excellent. So we have about 2 minutes left. I really want to take these next 120 seconds. And first of all, thanks Dr. D for his invaluable insights and actual experience. I bet, if I ever see one of these, I'll just call up Sabe. It's like, explain to me the roadmap. And thank you. And it's always on my quick dial. And I also want to thank Dr. Coppolite Priya. I think she's just walking out for all her contribution. And oh, you're still here, right? So
Okay.
now I can really thank you that for with all your connections around the countries and being able to actually bring in lots of guest faculties and friends from across the country to actually speak at our virtual echo meetings, and all our echo fellows for your contribution in the last year, because we only have about a week or two left in our training program. So good luck with all your future endeavors. I'm sure you do very well and spread far and wide, what you have learned, and also our St. Michael's virtual echo rounds. So thank you.